There's a lot of buzz around menopause, perimenopause, hormone declines, and hormone replacement therapy. But how do you evaluate all the different types of advice? How do you know who knows what they're talking about? As a gynecologist for 30 years, I'm embarrassed to say that the things I learned, a lot of it I didn't learn in my original training. I had to go get educated elsewhere. Scientific studies, reading those, conferences on midlife wellness, hormone replacement therapy. What's the difference between normal range and optimum range? What's the difference between being healthy versus sick? Because there's a huge difference. I want to share with you some of the issues and some of the problems that we face when we're trying to evaluate studies on hormone replacement therapy and experts who talk about hormone replacement therapy. I just want you to be informed. What hormones are we talking about? I mean, there's so many different hormones. The ones that we know for sure decline in perimenopause and menopause. Well, in perimenopause, they fluctuate. They can be high or low and back and forth, which is part of what causes this roller coaster ride. But in menopause, they decline, and that's estrogen and progesterone. But here, I even just did it. There is no such hormone as estrogen. We use the term in medicine for estradiol, estriol, and estrone. Those are the three types of estrogen that are biologically active. But we lump them all together and call them estrogen. It makes it difficult because you're just not being as specific when you talk about things. Another difficulty is with progesterone. And I've even heard experts say this. They use the term progestin or progestogen. Those are not hormones. There is no hormone called progestin. There is no biological chemical structure called a progestogen. And this is what really bothers me. We lump those together to be anything that has a protective effect on the uterus, that has a chemical structure similar to biological progesterone. But here's the thing, shape determines function. It's like a key in a lock. You need to have the right keys to open up the locks and not open up other doors. You know, when you hear of some of the side effects of different medicines or hormones or whatever, most of those side effects are because it's triggering a reaction differently to the one they want. We give you these things to either block a pathway or encourage a certain pathway, and that is the key unlocking that door. But when there's a side effect, then that usually means that that key fits in another door also, and it's unlocking a door that we don't want. The thing is, if you have perfectly forged keys that are bioidentical, it's so much less likely to unlock other doors and cause other side effects. This is just biological sense. You don't need a randomized clinical trial to prove that. The term bioidentical is something that a lot of conventional doctors poo-poo. Oh, that's just a word they made up. Yeah, we did, but we made it up for a reason. Because what it means is at the molecular structure, when you're looking at carbon, oxygen, hydrogen, how are they interlocked together? What shape does this molecule have? What shape does the key have? When you're looking at the molecular structure of a bioidentical hormone, it has the exact molecular structure of what your ovaries used to make. I'm sorry. It doesn't take a rocket scientist to make the statement, well, if it's available in the exact molecular structure, wouldn't that be what you want to use? Well, why don't we then? Well, some of it may have to do with ease of finding or making. Unfortunately, I think a lot of it has to do with money, because these big companies make money when they can patent something and sell it for a high price, and you can't patent something that is made in nature biologically. There's a big monetary gain to saying, oh, that's hogwash. Any kind of estrogen is fine. Forgive me for taking my hands off the wheel. I get passionate about this. So when we're evaluating studies and they're saying, oh, yes, but estrogen causes this, or progestogens or progestins cause that, you can't say that those are the things that bioidentical progesterone would cause. Those are different keys. They're different shapes. In fact, when we go back and we reevaluate the Women's Health Initiative, which was the bombshell study that came out in 2002, after which all women were afraid to death of hormones, and it made the evening news to get off your hormones because they cause cancer. When they went back and looked at that study and they evaluated women who were on bioidentical progesterone or no progestin versus the form of progesterone-like hormone, I'm not going to give the term progestogen or progestin lip service because it doesn't exist, so I'll say progesterone-like substance. When they evaluated what was used in that study, it was medroxyprogesterone acetate. That is not progesterone. It's a key that has a shape similar to progesterone, so it does protect the uterus from unopposed estrogen, which leads to hyperstimulation of the endometrium, and over time, prolonged hyperstimulation of the endometrium increases your risk of endometrial cancer. They looked at that and said, well, yes, it protects the uterus, but those women who were on that substance had the higher risk of breast cancer. And the women who weren't taking the progestin, or I'm sorry, there I go again, it's ingrained in me. Women who weren't taking the progesterone-like hormone, either because they'd had a hysterectomy and they were told they didn't need it, or maybe they were on micronized progesterone, they didn't have the breast cancer risk. Why weren't we told this? That makes me mad, and it should make you mad. And the estrogen that they evaluated in the Women's Health Initiative was not estradiol or estrone or estriol. It was Premarin, which is equine estrogen, which means it comes from horse urine. It's natural, but it's not estradiol. It's what we call equine estrogens or conjugated equine estrogens. So they just take all the hormones that a pregnant mare makes, isolate them, and put them in a pill, and it eases hot flashes. It helped with the menopausal symptoms. When we look at that, how are you supposed to pull that out in the data? It's hard because all these studies that look at risks and benefits of hormones, they lump estrogen together as estrogen. Most of them are not distinguishing whether it's conjugated equine estrogens, whether it's estradiol, whether it's ethinyl estradiol, which is the only form of estrogen that's available in oral form, which is what's in birth control pills and which is in a lot of the oral formulations of hormone replacement. They just lump them all together, and they lump all the different progesterone-like hormones together, and they call them progestogens or progestins. They don't distinguish who was truly on estradiol or estriol or estrone and who was on progesterone versus medroxyprogesterone acetate versus norethindrone versus whatever. There's so many different forms of progesterone-like hormones that are not progesterone. They do serve their function in the uterus, but the keys unlock a lot of other doors, and some of those we don't want unlocked. So I just want you to understand that it's not easy to fight this fight. It's not easy to say what is good, what is bad, how do we promote health, how do we evaluate truly what is good, what is helpful versus harmful. But let's use our common sense. If it's available in the form that God made it, that our bodies are used to, why not start there? And that's bioidentical hormone replacement therapy.